Now, I would say the more difficult than the CCS, which people have actually voted in last 4 years, is the CBS. Now, I would be straight come to the main point, that is what are the high yield recurrent themes that actually test the ICU concept. Yeah. So the CBS is somehow people find it difficult. Why? Because there are a lot of questions in, I would say, 36 minutes or 40 minutes for three stations, and the time period is also very short. So you have to think about, you have to look at the question, then you have to answer, and then based on the answer, you have to proceed to the next question or wait for some time or again come back to the previous question. It is a difficult task somehow. We all have experienced this. So that's why I would be first highlighting what are the high yield recurrent themes those were asked in the last 2 to 3 sessions. One is the shock differentiation. Dr. Sanand has also mentioned about in cardiovascular critical care that what are the types of shock is always a one of the hot topic. Sepsis recognition. We all know it, we all treat it, but in the exam, you have to answer it to the point. Mechanical ventilation troubleshooting, always a favorite among the examinees. ECG interpretation, lot of ECGs are right now being asked. It's not the simple ECGs, just like first degree heart block, or like I would say some of the ECGs like arterial fibrillation. No, rather they are asking something related to syndromic approach. They are asking something related to metabolic and electrolyte disturbances, something very congenital or rare like ECGs also. So you have to know in detail. Neuroimaging, yes, it includes CT, brain, it includes the CT angiography, MR also, spine CT also. So a lot of things being asked in the neuro side. Then source control, maybe intra-abdominal sepsis, post-operative status, bleeding following surgery, maybe sepsis, maybe acute pyelonephritis. So source control is always being asked as how the candidate is actually agreeing to do the source control rather than bombarding with the antibiotic and fluid resuscitation only. Anticoagulation, yes, this is a hot favorite among the examinees. And also electrolyte emergencies. It includes everything: hyponatremia, diabetic ketoacidosis, honk. Maybe it is due to the SIADH or cerebral salt wasting syndrome. So anything is possible related to electrolytes and some or other ICU complications, because here the examinee wants to know as you are going to be attending or consultant in your respective ICUs, how you are going to handle if some complication happens during the ICU course. So that is something they want to check. Are you ready for the consultant position? So that is something the reason behind they will somehow find it very comfortable in actually inserting one complication vignette among 3 to 4 vignettes they normally show during the CCS and also in the CBS as a spot diagnosis. And last but not the least, post-operative deterioration. The reason is same. Something happened intraoperatively or post-operatively. The patient is in ICU or shifted to ICU. How you are going to handle the complication? How you are going to communicate to the family? How you form a team where the surgeon, the anesthetist, the intensivist, and some others specialist would be forming a common decision to save the patient. So that is the essence behind this type of question setting. Now, again and again, I always highlight we need to understand the pattern, and the pattern is something which we have to crack. Then only your examination preparation would be successful. And here, the pattern in CBS, I'm not talking about CCS. Dr. Sanand has elaborately described about the pattern, how to crack the CCS. But CBS, where you have only 1 minute time, so the most important thing is recognition. What do you see? And the next question, if the examination is not involving the diagnosis part, rather maybe they would be straightforward asking how you are going to approach this patient or how you are going to manage this patient. But before that, you have to be thorough. What is the diagnosis? Without diagnosis, you cannot approach or you cannot just manage and treat the patient. So what is likely happening here? We are not discussing about the definitive diagnosis, maybe with a 2 line clinical vignette in the CBS, but definitely whatever they are actually giving, that is actually the clue they are actually providing for framing a differential diagnosis or two to three differential diagnosis. Now the next one would be immediate management. That would be a favorite question. Now, after the immediate management, maybe they would be keen to know what would be your definitive management. If the diagnosis is so clear and you have already resuscitated the patient, started the treatment, so definitely the next thing the examiner would be very keen to ask is definitive management. Then complications I have already highlighted. They would be very keen to ask about something or other complication that has happened during the course of the treatment due to some procedure, due to the surgery or something heterogenic. And finally, some of the investigations, very common investigation, how we are actually picking up those investigation and how we are going to address that. Now, important skills being assessed in CBS, it is all very practical and they do it very I would say scientific way. Everyone in this discussion, all the faculties will also agree. They will not pick up any question here and there that this time they let's ask this question. No, the examination is very methodical and very scientifically proven. So that's why they always pick up the questions based on the merit. Okay, and they also want to know from that question what would be the skill they want to assess from the candidate. Now, ICU prioritization, that would be the first skill they want to know or check whether you are ready for the ICU consultant, that you are prioritizing. There are 5 things to do in front of you, but how you are going to prioritize that this one is the first one and this one is the second one and this one is the third one, because it is a time tested the procedure you are actually doing in the ICU. Now, structured thinking, if you are answering something, it should not be however you are talking something from your mind, but there is no I would say coherence between the options or the answers. So that is the second one. Third one is image interpretation. If they would be showing you something, maybe X-ray, maybe the CT scan, maybe focus finding, maybe something related to ONST, so they expect you to interpret that image, and they may share it in a form of a snapshot or maybe a short reel or video. Emergency management, it's not only about the definitive management. I have already told you emergency management, because here comes the role of the critical care specialist or emergency physician. Now, differential diagnosis, communication clarity, so that is one thing. Now gradually ADC examinees are actually the examiners are actually expecting the examinees how they are so clear about the communication part, or it is only the management part they are doing, the communication part they are still lacking the skill. So that is something now they are assessing. And everything whatever you are saying, it is not your own eminence based management, rather it is the evidence based management that they want to check. Now, likely examiner expectations, a good answer should include structured interpretation, prioritization of the live threats, ICU stabilization, definitive management, relevant investigation, and monitoring plan. What you are going to do in the next 2 days, next 3 days, next 24 hours, next 6 hours, that also along with the monitoring that you want to highlight. Now, I would be giving you a short clue how you are going to improve your CBS performance. Maybe every day you try to create a CBS question on your own. Though we have lot of CBS questions, as Dr. Sanand has told from our repository, we will be coming up with also every week domain based CBS questions. So CBS question will be almost having 500 CBS question at the end of the course in our app and in our website. But still I would be advising you to create or think about CBS questions in your daily ICU practice. So a 2-minute structured case presentation where maybe your colleague would be standing in front of you and you as the examinee, you are planning you are the examinee who will be going to appear the edict to exam. You would be describing what is this case, what is the ECG finding, how you are going to address this image, ICU image, CT scan, and what are the rapid differential diagnosis and immediate next step question. Maybe in the ICU you will not be able to discuss in detail because of your work pressure. There will be a lot of things you have to do. It's not only examination preparation, but I would definitely expect that at least 2 to 3 next step questions you can frame and answer to your colleague. So that would be making you ready for the big day, that is the addictive exam, rather than you know everything, you assume that you know everything, but in the real exam, real show, you falter. That we don't want you to do. We have got feedback for last 4 years. People are answering everything perfectly during our the examination, mock exam, our domains. But in the real exam, in the mock exam that we do at the last 1 month before the exam, they falter. Now, I would be now coming to the hot domains from the recent EDIC CBS. This was what was tested, why it was tested, and what will repeat. Now, key EDIC to shift very clear, image-based CBS. They want decision-making CBS. No more name the diagnosis, what will be the definitive diagnosis, or what will be the definitive management, what is the syndrome named as. No, they don't. I expect this type of theoretical answer in the CBS. Rather, the idea behind the CBS question: what kills the patient next? What do you do in 5 minutes? What complications are you missing? So CBS is not equal to radiology viva in our training period. Rather, it is ICU thinking under time pressure. That would be, I think, the take-home message for all of you. Now, imaging-based ICU assessment modalities covered. I would be not describing a single vignette wise. Rather, I would be giving you as a whole comprehensive holistic approach in the imaging. So that is one of the station in the CBS. CT brain, CT chest, CT abdomen. So all the CTs are actually favorite, along with the MRI spine. Maybe the spine fractures, injuries, they will be expecting you to know. Chest X-ray, lung ultrasound, which is now every day we are doing in our respective ICUs. Along with now they are more keen to enter into the brain angiogram also. CT angiogram, MR angiogram. So they would be expecting you to know also. Now, focus, focus, focus. So let's focus the focus, because now it is one of the most common, I would say, intervention or procedure or diagnostic modality that we do every day. So anything and everything they can ask you from head to toe. So that's the clue that I can share with you. Now coming to the toxicology domain, the topics covered in last 2 sessions: methamphetamine toxicity, paracetamol toxicity, smoke inhalation, carbon monoxide poisoning, cyanide poisoning, and the questions asked were, I would be just giving you some of the favorite questions that those were asked. Toxic alcohol metabolic acidosis interpretation because of the seizures in our patient. What is the antidote therapy? And what are the hyperbaric oxygen indications? Those were the questions. Now, there was a question: anticholinergic versus serotonin syndrome. Now, the question started with agitated febrile patient after overdose. That was the question. I have reframed it, and that's the reason why you should know what are the differences between anticholinergic and serotonin syndrome. That I am not going to teach you. This is not a theoretical or descriptive class. Rather, it's just one snapshot of the things that those were asked in the recent EDIC 2 exam. Now, the clinical pearl here: dry skin plus absent bowel sounds, anticholinergic. If your patient is having clonus, that is, or hyperreflexia, maybe that patient is having serotonin syndrome. Clear? Now, salicylate toxicity is one of the questions that was asked. The vignette was around patient presented with tinnitus, vomiting, tachypnea, mixed respiratory alkalosis, and metabolic acidosis. So both mixed, respiratory alkalosis plus metabolic acidosis. So what was the diagnosis? What is the key management? And what are the dialysis indications in the salicylate toxicity? So those were the questions and the clinical vignette that was asked in the recent exams. And the pearl is: intubation can kill if minute ventilation is not maintained. So because of the metabolic disturbance as well as the respiratory disturbance. Now let's come to the cardiovascular critical care related to CBS. So the topics covered were junctional rhythm, AV block, atrial fibrillation with slow ventricular response. That was the difference. Normally we expect atrial fibrillation with fast ventricular rate, but the question was atrial fibrillation with slow ventricular response. Okay. Now that was like, that means AF with a variable AV block. So that's the reason why the ventricle will not respond to the normal atrial fibrillation with a fast ventricular rate. Cardiac tamponade, cardiogenic shock, pulmonary embolism with shock. Again, the differentiation of different types of the shock. It includes everything. Now the questions asked were ECG interpretation, Canon A waves in CVP tracing, pacemaker indications. This is one of the very favorite I would say high yield domain, and we have a very good short video also related to pacemaker and IABP that we have created. Management of AV dissociation, massive PE management, the recent guidelines, shock evaluation, and echo based assessment. These are the questions those were asked. Now I am giving you again a question that was asked, reframed it: post CABG patient, rising CVP, hypotension, high venous PCO2 gap, and low venous saturation. So the diagnosis they expected: due to obstructive shock, cardiac tamponade until proven otherwise. What was the next best investigation? Urgent bedside echocardiography, TEE, transesophageal echocardiography, and the management: call the cardiovascular surgeon, prepare for re-exploration, optimize preload temporarily, vasopressors, and avoid delay in the definitive management. So clinical pearl here: post cardiac surgery tamponade may not show classic echo signs. That may be one of the thing that would be confounding. Now ECG patterns, ECG diagnosis, I'm just showing you. Some of you should be able to diagnose what is the ECG diagnosis in this patient. If not, then another ECG. Again, I'm not here to teach you ECG. That can take 3 hours today if we will start discussing about the ECG. But the ECG in the first one that I have shown is hyperkalemia pattern, that we all should be very thorough. And again, the answer would be, what would be the management? You have to answer it. What are the ECG findings? That you have to answer. Then the second one that I have shown you is pulmonary embolism, right ventricular strain pattern. And again, the prompts here: sinus tachycardia, S1Q3T3, T inversion, right ventricular strain pattern, and answers for the the diagnosis: massive or submassive P, how we are going to confirm it, what will be your management plan. Now coming to the respiratory and mechanical ventilation domain, topics covered in the CBS: intrinsic PEEP, bronchospasm, pneumothorax, pleural effusion, ARDS, lung ultrasound, ventilator alarms. And the questions those were asked are: expiratory hold maneuver, dynamic hyperinflation, tension pneumothorax recognition at the bedside, CT chest interpretation, pneumonia with ventilator complications, air bronchogram interpretation, then how you will be differentiating between lung collapse versus lung consolidation. So these are the questions those were asked. Now I have a question for you from the CBS simulated. The vignette was post thoracic surgery patient with a milky chest drain output. That was the recent one edict to exam CBS. Diagnosis was chylothorax, and how you are going to confirm it: pleural fluid triglyceride more than 110 milligram per deciliter and chylomicrons positive. How we are going to manage? Drain it, low fat or MCT diet or TPN, octreotide, treat the cause, thoracic duct embolization or ligation if you are persistently get high output. So the pearl here is, milky fluid is not always pus. Check triglyceride. That would be also useful for your clinical practice. Now another question this time asked: desaturation after weaning with esophageal stent. Now the vignette was: patient with esophageal stent desaturates after weaning. CT chest shows aspiration changes, collapse, possible tracheoesophageal communication. Now likely cause: aspiration pneumonia, stent migration, tracheoesophageal fistula, airway compression, or post extubation atelectasis. This could be the cause of this sudden desaturation. Now what you will be looking for on CT scan: stent position, airway compression, fistulous tract, aspiration consolidation, pleural collection, or pneumomediastinum because of this stent migration and injury because of this tracheoesophageal fistula. Now how we are going to manage it: oxygen NIV cautiously, bronchoscopy, Antibiotics if aspiration, keep NPO, surgical or GI review, reposition or remove stent, and airway protection if recurrent aspiration happens. Now the clinical pearl here in esophageal stent patients, desaturation may be mechanical, infective, or fistulous. Right. Now, this was one of the question again asked. What has happened here? Somebody, if you can answer. Just to know, are you with me? Your GCS is 15 by 15. What is the ECG? What is the mechanical ventilatory like the trouble? Like how you are going to troubleshoot this? What has happened here? Anyone? This has been also marked here. Here. This is the volume assisted. This is the pressure assisted. And this is the esophageal pressure. What is happening here? Anyone? Yes. Yes. Excellent. Excellent. Sundari Thirulo, Dr. Thirulo, you are perfectly damn on the point. So these ventilator graphics here, ventilator pressure time curve is scooped, patient using accessory muscles that you can see in the esophageal pressure monitoring. Diagnosis, flow starvation or insufficient inspiratory flow. The cause here is high demand, low set flow, inappropriate rise time, pain or anxiety, fever, acidosis. Okay, these are the causes that can cause flow starvation. How we are going to manage the flow starvation? Manage inspiratory flow, adjust rise time, pressure support, treat the demand, sedation or analgesia. Okay, so concave pressure curve, patient wants more flow. That is the clinical pearl. Now oscillations on ventilator waveform, they have shown oscillations on the ventilator waveform and the answer was cardiac oscillations, cardiogenic oscillation, often seen with low flow or highly sensitive trigger. So the risk here will be auto triggering. Now this cardiogenic oscillation would be creating or act as the triggers to initiate the breathing. Now management, reduce the trigger sensitivity, check circuit water leak and adjust the flow or the PEEP. Not every waveform vibration is actually patient effort. That is the clinical pearl. Now coming to the neurocritical care, the topics covered, brain death, mandatory you have to know, intracerebral hemorrhage, ischemic stroke, cerebellar infarct, traumatic brain injury, raised ICP, hydrocephalus, seizure, spinal cord injury, watershed infarct. And the questions those were asked, CT brain interpretation, brain angiogram finding, ICP management priorities, decompressive craniectomy indication, neurologic deterioration cause, MRI cervical spine interpretation, thiopenton related electrolyte issue. Which electrolyte is actually mainly affected if you have thiopenton toxicity or the patient is receiving thiopenton? Anyone? Anyone who wants to try thiopenton related which electrolyte issue? The examiner would be keen to know. Yeah. Okay. Perfect. Okay. So these are the things that you need to know. And there was one question I am just sharing with you. Post cardiac arrest patient, low GCS. CT shows diffuse sulcal hyperdensity, mimicking subarachnoid hemorrhage. Now, the diagnosis, likely diagnosis, pseudo subarachnoid hemorrhage due to severe cerebral edema. So sometimes you will be confused whether it is true SIH or pseudo SIH. How to differentiate? Low Hounsfield unit density, diffuse cerebral edema would be there, effaced sulci and cistern because of this post cardiac arrest, poor gray white differentiation, no aneurysmal bleed pattern. So again, the pattern would be something different. Now the management priorities here, neuroprognostication delay, treat the cerebral edema, maintain MAP and the cerebral perfusion pressure, avoid the different secondary injury inducing the factors, hypoxia, hypercapnia, etc. Repeat imaging or CT angio if doubt. So the clinical pearl here, not every subarachnoid hemorrhage like CT after arrest is aneurysmal subarachnoid hemorrhage. So that is actually pseudo subarachnoid hemorrhage due to severe cerebral edema. Now, there was a question again, ICP waveform, P1 merged with P2. Now the vignette was traumatic brain injury patient with rising ICP. Now ICP waveform shows P2 is equal or higher than P1. So very straightforward question. We all know it because of the poor intracranial compliance. The immediate causes are cerebral edema, mass lesion, hydrocephalus, venous obstruction, or hypercapnia. And the management, we all know how to manage the ICP, tear-based, head elevation, analgesia or sedation, normocapnia, hyperosmolar therapy, CSF drainage, if you have EVD, CT brain, and neurosurgical review. So clinical pearl here, rising P2 is an early warning before the catastrophic ICP crisis. Now, one hot domain which is from coagulopathy and ROTEM. Now, the CBS questions, those were asked related to ROTEM or the coagulopathy or TEG, diffuse bleeding post-vascular surgery, ROTEM traces source. Eddie would be expecting you to know what are the factors that is deficient in the patient, whether it is due to fibrinogen deficiency or hyperfibrinolysis. Again, the targeted blood product therapy, because TEG or ROTEM, if your hospital or your ICU has, that would be helping you not to go for liberal blood transfusion or blood product transfusion, rather targeted blood product therapy. And again, this was one of the topic that we have actually created a video for our trainees about the TEG and ROTEM. So the trend for this TEG and ROTEM is actually the most important contribution to the critical care. Move from the FFP per all to goal directed hemostasis. Okay. Now the next hot domain is ECG based critical diagnosis. Now here multiple CBS tasks. I have already told you about the ECG or the diagnosis favorite question. Hypothermia ECG is one of the most important ECG that you should know. Okay. So ECG based critical diagnosis, multiple CBS tasks, hypothermia ECG, Holter strip post syncope, seizure plus ECG changes, they would be creating that clinical vignette, and you would be expected to answer this. And the key ECG concept tested here: Osborne J waves, malignant arrhythmia, electrolyte driven changes. And it's not about the rhythm naming. Try to understand. The trend is now to know or answer what is the physiology behind it and how you are going to manage it. That you need to crack. Okay. With this, the last thing that I want to highlight here from the CBS, Dr. Niharika would be adding again 5 domains which I have left for her. But my take home here would be again pattern recognition, prioritization, ICU appropriate next step. Maybe you should not be talking about you are in the OPD and you are dealing with the internal medicine. Rather, it is the acute care medicine that you should do, and avoid over investigation. Think like an intensivist, not an examiner. So that's with this I want to end up my talk. And already Dr. Sanand has shared the core structure that we are bringing. So you can see here lot of CBS questions that we are coming up. So at the end of 4 months, if you are starting, so you would be almost covering more than 400 CBS questions and almost 50 CCS questions. That would be too much for your revision and getting the confidence. Thank you very much for your patient listening.